she's having an annual wellness visit, woman visit, and she complains of the vaginal dryness, but she's having a pap at a pelvic, and her prescriptions are just being renewed. There is really nothing there that can justify an additional visit. The patient also requests advice on hormone replacement therapy. She is anticipating menopause, but is currently asymptomatic, which means no symptoms. This would not be considered significant because the patient is asymptomatic. And preventive medicine services include counseling or guidance on issues common to the patient's age group. So even if a patient has diabetes or hypertension, but everything is under control and there are no alterations or any complications that stem from it, it would still be preventive. Now, an example of significant services. The patient also complains during her preventive of night sweats, hot flashes, and lighter, irregular menses. And after a discussion of treatment options, risks, and benefits, a prescription for estrogen replacement is given. Because the patient is symptomatic and additional history is taken along with the medical decision-making, this is considered significant. And in this case, the diagnosis code for menopause would be linked to the E&M code, and then the preventive exam might be Z00.00 or whatever for the preventive exam. And you would append the 25 to the E&M service if it was, say, a 99213. Here's another example. The patient also complains of fatigue, hair loss, feeling cold, and lighter menses. On exam, mild hair thinning and areflexia, which is below normal or absent reflexes, are noted. The physician orders a complete blood count and thyroid stimulating hormone test with the intention of writing a prescription after reviewing the test results. So because symptoms are present and the physician documents extra work in all three E&M key components, this would be considered significant as well. And the diagnosis codes for the symptoms would be linked to the E&M code. The patient can also complain of a bilateral knee pain in the morning. Tenderness and swelling are found on exam. The patient is given a non-steroidal anti-inflammatory drug prescription. The extra physician work that is documented for all three E&M key components makes this significant. And the diagnosis code for knee pain would be linked to the E&M. So those really do stand out. Here we have the patient states that home monitoring has shown fasting blood sugars of 120 milligrams over DL to 180 milligrams over DL, and some random sugars over 300 milligrams DL. This is a significant problem that needs to be addressed, and extra physician work is done and documented for all three E&M components, and the diagnosis for uncontrolled diabetes would be linked to the E&M code. Now, the status of a previously diagnosed stable condition, such as the diabetes, would be considered, as I said earlier, part of the preventive medicine service and would not be separately billable. But based on these blood sugars, there is a problem, and that's why that would be a separate visit. Now, if the diagnosis will be the same, did the doctor perform extra work that went above and beyond the typical pre- or post-operative work associated with the procedure code? We'll talk about minor procedures. The CPT codes for minor surgical procedures include pre- and post-op evaluation services. Those are actually bundled into the surgical procedure, okay, such as assessing the site or problem, explaining the procedure and risks and benefits, and obtaining the patient consent. Also, CMS, Medicare, and Medicaid clarified that the initial evaluation is always included in the reimbursement for a minor surgical procedure and therefore is not separately billable. But there are exceptions, so we'll look at them. Here's the first one. The patient complains of a troublesome lesion, so the doctor looks at the lesion and he removes one wart at that visit. The surgical code includes the evaluation services necessary before the procedure, performance of the procedure. So no E&M code should be billed. And the CPT code would be 17110, destruction. Example, laser, electrosurgery, cryosurgery, chemosurgery, or surgical correctment of benign lesions other than skin tags or cutaneous vascular proliferative lesions, up to 14 lesions. And just to show you, this was a surgical correctment. This is the tool, and this is how the lesion would be removed. And this is cryosurgery. Okay, so because he looked and it was just a basic wart, there really wasn't too much going on there. He kind of assessed it and said, okay, let's get rid of it. And so sure, there is no E&M with that. And a lot of doctors do have a problem with that. Now, example of billing a minor procedure and an E&M. Let's say that at a follow-up visit for the patient's stable hypertension and osteoarthritis, the patient also complains of a troublesome skin lesion and the doctor removes it at the same encounter. These services are separate and significant and not part of the pre-op service for the lesion removal. The code for the lesion removal would be linked to the appropriate lesion diagnosis code, and then the E&M would be linked to the hypertension and osteoarthritis diagnosis codes. So that would be an example when you would actually use the E&M with the modifier 25 because it is a minor surgery, and then you would do the minor surgery code. Now here we have the patient presents with the head laceration, and you examine the patient, or the doctor examines the patient for neurological damage before repairing the laceration. It would be appropriate to bill both an E&M service and a laceration repair code because your work was above and beyond what is typically associated with a routine pre-op assessment of a laceration. So a separate diagnosis would not be necessary. You could actually use, the laceration, the head laceration as the diagnosis code. So you would code the 99213 with the modifier 25 because it's still a minor procedure, and that's verifying basically the neurological injury, and then say it was a 12032, a layer closure of a scalp wound. CPT code 12032 does have a 10-day global period, so modifier 25 is appended to the CPT 99213. And if you look at the National Correct Coding Initiative and you see that indicator 1 in the in the columns, can you bill this with this? If it said 0, that would mean never could you bill these two together. But the indicator 1 was attached to the laceration, and that's saying that you could bill the visit with it. And because it is minor, we're only using the modifier 25, okay, which is a 10-day global, 0 to 10-day global, where if this happened and it was a major surgery being done on the head after an accident, that would be a decision for surgery, which would be modifier 57. But this is not. This is just a basic head laceration. Now, a patient visits the cardiologist for an appointment complaining of occasional chest discomfort during exercise. The patient has a history of hypertension and high cholesterol. After the patient completes an office visit, it is determined that the patient needs a cardiovascular stress test that is performed that day by the same physician. So when we're coding for example 1, the physician codes an E&M visit, which would be anywhere, depending on his documentation, the 99201 to 99215, and he would also code for the cardiovascular stress test in his office, the 93015. The modifier 25 again would be appended to the E&M visit to indicate that it was a separately identifiable E&M on the same day of a procedure. Okay. Now, the modifier stops the bundling of the E&M visit into the procedure. And if any of you have ever done medical billing, how many times have you forgotten to append the modifier 25 to an E&M when you've done another procedure with it, and they only pay one of the two, and then you have to go through the whole appeal process. But that's exactly what happens. If you forget to add the modifier 25, typically insurance will pay the lesser of the two, and you have to go back and appeal it with justification as to why you should be billing both of them together. So as always, the documentation has to support the claim so that if the carrier requests information. And I'll be honest, I've never had a request in my 37 years of billing and coding for minor surgeries, but I've certainly had plenty for major surgeries. So you want to make sure that the modifiers are appended. Here would be a reason not to use an E&M with the modifier 25. When a patient is scheduled ahead of time to come into the office for the cardiovascular stress test. Say she was seen the week before for a problem and they scheduled her just to come in for the cardiovascular stress test. The physician would complete a history and perform a limited exam specifically related to the stress test. So that's all you would be billing is the stress test. Okay, so Whitney has a question. Say, I have a question that is a little off topic, but it does have to do with using an E&M. A patient came into the emergency room for fainting and seizures, and a neurodoctor saw the patient in the ER. So if you are billing for the neurodoctor, would you use an ER visit code like a 99285? I know you like to bill a 99285 for the ER doctor, but I was told to bill a 99285 for the neurodoctor too. Is this correct? Yes, it is correct, Whitney. In fact, I do coding for physicians in a small hospital, and there are numerous specialists. And sometimes when an accident comes in, I do have multiple specialties working, and they all code the ER visit. There's no, and none of them get denied. Because they're different specialties, different practices on call at the ER and so forth. So it's definitely okay to do that. So here's some more tips. Do not use the 25 modifier when billing for services performed during a post-op period if related to the previous surgery. Don't append 25 if there is only an E&M service performed during an office visit, which is somewhat of a no-brainer because no procedure is done. Don't use a modifier 25 on any E&M on a day a major 90-day global procedure is being performed. That would be a modifier 57. And many times, I have patients that go in and see the doctor the day before, and then they have a major surgery the next day, and I do not bill for that visit. But there are other times for the same doctor that he is being consulted in an emergency situation, and within 24 hours, they're either right there doing the surgery, or within 24 hours, they're doing surgery. And I do bill for that visit with a modifier 57, a decision for surgery, and then I bill the surgical procedure. Do not append modifier 25 to an E&M when a minimal procedure is performed on the same day, unless the level of service can be supported as significant, separately identifiable. All procedures have inherent E&M service included. And also, patient came in for a scheduled procedure, such as the stress test. So if it's very basic, and I really think the wart removal is the best one because it really doesn't require a whole lot of time for the doctor to just look and say, yep, that's a wart, let's get rid of it, it's bothering you or whatever. It just makes sense. Modifiers are needed to inform third-party payers of circumstances that may affect the way payment is made. The modifiers tell a story of what is actually being done, but always remember to link the modifier to the E&M CPT code. A lot of times I get questions, well, do I add it to the procedure? No, this is for an E&M CPT code, and it's not necessary to have two different diagnosis codes, like the head laceration, but you want to make sure that the doctor's documentation qualifies for both. Here is one where the modifier 25 on the E&M code is not necessary when also reporting a diagnostic testing code such as an EKG, audiogram, or CAT scan. However, you might find that some payers, and this is very true, require the use of modifier 25, but it is not a CPT coding requirement. And so you'll find that, this is really one of those situations where, and when you get the denial and you make a call or you go online and research it, you may find, the rules vary a little bit. But a diagnostic test typically is a procedure performed to confirm or determine the presence of disease in an individual suspected of having the disease, usually following the reports of symptoms or based on the results of other medical tests. So for example, if we did an E&M visit for a cardiac evaluation and an EKG, I would never append a modifier 25 to Blue Shield, my Blue Shield, which is NGS Medicare, Blue Shield or my Medicare, which is NGS, that's what I say. And I wrote here per Medicare, CPT modifier is not required because it's diagnostic. See, I see modifier 25 used all the time on ER visits, such as the patient had a simple laceration repair or an incision and drainage. I know, and you know what? That's okay to append the modifier 25 to the ER visit. It most likely will get paid. I mean, it's still considered an E&M code because it's just emergency room, but definitely yes. And I've done that as well. So there's nothing wrong with that. Again, though, you know, sometimes an incision and drainage, they may not, it should be either the ER visit or the actual procedure that's being done. But I've never really run into a situation, whether I've been auditing or doing coding myself, where the ER, I'm sorry, with the modifier 25 and a procedure got denied. So if it's working, then it's fine. So basically, when a standardized screening or assessment is administered along with an E&M, and I say like preventive medicine service, the depression screening, or any of these new screenings that take place, both services should be reported and the modifier would be added to the E&M code, okay? And so they're just showing that it's two separately identifiable type of tests that are being done, you know, on the same visit. Now, here's an example, and I get this a lot, where we have a 99393 with the modifier 25, and that is a preventive visit, but it's the only E&M code that we're using. And it's for a kid that's established 5 to 11 years old, and it's an encounter for a routine child health exam without any abnormal findings. So the diagnosis is the Z00.129, because there are no abnormal findings. Now, when we look at all of that, what was done, the doctor first injected the hepatitis A vaccine, and this is the product, okay? Then we code the 90460, which is the administration and counseling of the hepatitis A vaccine. Because this one shot only had Hep A in it, you're going to use the 90460, okay? And that is linked to the hepatitis A vaccine. Then the doctor also gave a DTaP, which is diphtheria, tetanus, and pertussis. And that is the whole vaccine. So this one shot had 3 drugs in it. So that is the code. And all the Z23s here mean encounter for vaccination. But we have to break it up because counseling is involved in these administration codes. And so for the pediatrics, so we have the 90460, which is the first component of the injection. So that one's basically covering the administration of the diphtheria. Then we have 90461 times 2 units, because that's each additional vaccination. One's for the tetanus, one's for the pertussis, and that's 2 additional. And then the patient also got a flu shot. And the code for that particular flu shot, the preservative-free, was 90686. 1 vaccine in this one shot. So again, it's 90460, which is the first component. So I know that can be confusing sometimes to people that are coding administration of vaccines for pediatrics, but if they're doing the vaccination with the counseling, then most definitely you have to break it down by the number of vaccines that are in that one injection. Now, let's assume here that a 6-month-old patient goes to the office for her routine checkup and to receive vaccines. The patient is due for the DTaP, pneumococcal, and Hep B vaccines. But during the exam, the doctor finds an upper respiratory infection and fever. So the physician counsels the parent on the vaccines during this visit, you know, the well visit, but decides to defer the vaccinations for 2 weeks. So the physician completes the well baby checkup on that day. So he codes a 99391 with the Z00.121, which is an encounter for routine child health exam with abnormal findings. And then a 99213 with the modifier 25, which is the J06.9 upper respiratory infection. And the signs and symptoms of an upper respiratory infection are runny nose, nasal congestion, sneezing, cough, and sputum production. Those are the hallmark symptoms of URI. However, fever can also be a component. Now, personally, I probably would not add the fever. I would just use the J06.9, but because the hallmark symptoms are the runny nose and so forth, I figured I would put it in. It will not get my claim denied, but it just, depends. I know I remember sitting around a conference table with a bunch of coders that were all instructors at the AAPC, and we were in Salt Lake City, Utah, and had this discussion back then. And it really was how each coder read the documentation. And some just felt the URI, the J06.9, was sufficient, while others felt that the fever should be added. So we'll leave that up to you. But either way would be acceptable. The point here more is just to show how, because the baby was sick, it would just bill these two. But so here is how it would look for the first visit, say April 15th. Okay, just as I showed you. Then the baby goes back 2 weeks later. And look, because the doctor already counseled the patient 2 weeks ago, all we're billing here now is the DTaP product, the pneumococcal, and the Hep B. But look at the difference. We have 3 vaccines in this one shot. And then we have one component, in the pneumococcal and one component in the Hep B. These are the drug codes here. But because there's no counseling, we are not going to be breaking up this into a 90471 for the diphtheria, and then 90472 times 2 for the tetanus and pertussis. When there's no counseling, you will code for the first shot as a 90471, and then each additional 90472 for the pneumococcal and 90472 administration for the Hep B. So the baby was only seen on May 1st to get her vaccines. We don't bill the E&M. Counseling was included in the preventive exam on April 15th. Because there was no counseling on May 1st, we only use the 90471 and 72, and those rules and guidelines are different for administration of vaccines. Okay, now we're moving to the 2018 CPT Errata and technical corrections. The new information was provided April 16th. I actually got access to it around the 25th of April. And we were told that the effective date for these changes was retroactive to January 1st, 2018. There's a lot of these slides have a lot of words, and if I read everything, we would be here till midnight. So I am going to actually clarify certain things and read certain things. And I do want to tell you that if you have your CPT book, it would be a great idea to have it, but if not, that's okay, because you can tab the pages as we go through. But I also, if you use your CPT manual professional, I have indicated the pages on these slides that you can look at and what column, and then afterwards you could actually go in and change it. And at the end, I will actually give you the link to the AMA. So if you want to print it out instead of using my handouts or whatever, you're welcome to do that as well. But I just want to make sure, did I get all your questions? Let's see. A patient came into the ER, the patient expired. So a patient came to the ER and the code assigned was 99283. CPR was performed on the patient, but the patient expired. Will the 99283 need a modifier 25? I've been told to consider this situation like 2 procedures were performed, so it would need a 25. Just clarifying. For the CPR. I don't know. I'm gonna I'm trying to think, because I have coded for CPR before with critical care, and I've added a modifier 25, I thought. I would say probably you would add a modifier 25, but I would question that if the patient died on that day. Sometimes it's hard to get paid on the day the patient dies. So you may be dealing with two issues, but I don't think it would do any harm to add the modifier 25 to the emergency room visit, to add with the CPR. And honestly, if it ended up, the diagnoses might be different as well. I don't know. But if the insurance denies it because of the modifier 25, then you would just have to remove it. But it logically, it makes sense. But see, for me, I always will run into the correct coding initiative and double check to see if it's allowed. But typically I add the modifier 25 to a lot of that stuff. So it's so hard. If we could just go by the CPT manual, the way we're trained, it would be so easy. And honestly, I mean, that's our solid base. But once you really, and Whitney, I know for you especially, our hands are in so many different specialties and so many different things. And it ends up that sometimes what you learn in CPT is fine for a lot of the insurances, but then a lot of payers, and some that you use all the time, have their own set of rules. So it's kind of tough. But anyway, moving forward, you will find at the very beginning of the AMA errata, it will say the order of the entries that you're about to see in this document is by code order. Additionally, each entry shows the date of publication to this document. The links immediately following are provided as a guide to the most recently added items, and the effective date of each item is January 1st. Updates to this document are made as issues surface requiring clarification. And so if any of you are billers and you see changes involved in the codes that you typically use and the guidelines that you follow, then at least you'll know why money's being taken back, and then you can appeal it or make the necessary corrections. So again, I recommend that you if you have your CPT manual with you, it would make sense. You don't want to write the changes as I presented, but you might want to just tab the pages so you can go back and make changes. But if you do use the professional, I will give you most of the pages in the columns, so that will help you. When we see what's going to be coming, the deletions will always be in red with a line through it. Anything new will be in green and underlined. We will start with the revisions and changes. They will be introduced at the top of the slide, and they'll be in bold black. So the first code that we're going to look at, the revision. We will be revising the prolonged service without direct patient contact guidelines to mirror the prolonged service with direct contact guidelines and to provide rationale and guidance for services of less than 30 minutes. Clarify services reported with codes 99358 and 59 and add specific instruction to guide the appropriate use of these codes. A time chart was also added to clarify that time providing prolonged service without direct patient contact must pass the halfway point to align times in these services with the current time reporting conventions. So you want to see the coding tip under prolonged services of less than 30 minutes in the CPT, because prolonged service, less than 30 minutes total duration, is never coded or billed separately if it's under 30 minutes. Okay, so that is what we're going to be looking at next. And when we look here, we see the code 99358 and 99359 are used when a prolonged service is provided that is neither face-to-face time in the hospital or outpatient setting, nor additional unit floor time in the hospital or nursing facility setting during the same session of an evaluation and management service, and is beyond the usual physician or other qualified healthcare professional service time. And you'll see this written on page 33 of your CPT professional. This service is to be reported in relation to other physician and other qualified healthcare professional services, including E&M management services at any level. This prolonged service may be reported on a different date than the primary service to which it is related. For example, extensive record review may relate to a previous E&M service performed earlier and commences upon receipt of past records. However, it must relate to a service or patient where face-to-face patient care has occurred or will occur and relate to ongoing patient management. And a typical time for the primary service need not be established within the CPT code set. So where I have found the only time I've ever really used this CPT code, and a lot of times payers don't even like these two codes, but it's if I have a mom-to-be that's admitted into observation status because of certain complications or whatever, and the doctor checks her over and she's going to stay in observation, and then they'll determine whether they're going to send her home or admit her for delivery. And then the doctor leaves, but he's in the hospital on standby waiting, and the nurses and all the healthcare professionals there, like monitoring and doing whatever they do to the mom with the problem who's appears to be in labor. And if she's sent home, then she's sent home, and the doctor, if he has been on standby after he's checked her, in the observation status on the outpatient, then he can code the 99358 or whatever. And when they talk about different days, a lot of times a patient might be admitted, say, into observation at 10 or 11 at night. The doctor will check, the patient over and leave, but still be in the hospital to be called and is on standby. And then say the woman goes into delivery after midnight and it's the following day, you would use the 99358 or 59 then. So these are used to report the total duration of non-face-to-face time. And always the 99358 is used to report the first hour of prolonged service on a given date, regardless of the place of service, and it should be used only once per date. And then the 99359 is for each additional. Now, on page 33, column 2, you will see that they added prolonged service of less than 30 minutes total duration on a given date is not separately reported. But they added, because the work involved is included in the total work of the evaluation and management or psychotherapy codes. And that is on column 2, page 33. And then additional information is the code 99359 is used to report each additional 30 minutes beyond the first hour, regardless of the place of service. It may also be used to report the final 15 to 30 minutes of prolonged service on a given date. Prolonged service of less than 15 minutes beyond the first hour or less than 15 minutes beyond the final 30 minutes is not reported separately. Okay. Now on column 2, page 33, we will just look, all the information is the same in your CPT manual, but they added the word after medical team conferences 993 to 66 to 99368 or online medical evaluations 99444. So they added the word or, and then they crossed out all of the rest of this parenthetical, note, all this information in the guidelines, or other non-face-to-face services that have more specific codes and no upper time limit in the CPT code set. And codes 9935859 may be reported when related to other non-face-to-face service codes that have a published maximum time. Example, telephone services. So we're adding the word or, and then crossing out all of this. And that's on page 33. And here we see all of this on page 33 on the second column. But here, what's new, do not report 99358, 99359 during the same month with 99484. And then we have your 99487 through 99489, which was always there. And then they added 99490, 92, 93, and 94. So they've added all of these codes, okay? And that's where you would make your changes on the second column of page 33. Now, this table, when you look at the link from the AMA that I give you, it may actually be clearer for you if you don't like this one, but this is not in your CPT manual. It mirrors the prolonged services, okay? But this one is without the direct patient contact. So this is the prolonged service without the direct patient contact, and it looks exactly like the prolonged service with direct patient contact as far as the times and, you know, the ×1 and all of that. But obviously the codes are different. So you may want to get a smaller version from the AMA link and just tape it on or paperclip it to your page if this is something that you would typically use. Now here we have the changes, the telephone services, and it's saying to revise the exclusionary parenthetical note instruction within the telephone services introductory guidelines from performed to reported by the same provider. And that's page 39, column 1. So this guideline, we already have this all in our CPT manual, how the telephone services are non-face-to-face evaluation and management and so forth. We're familiar with that. What we have to change is these parenthetical note right here. Do not report the 99441 and 99443 if 99441 to 99444 have been reported by the same provider. So we're crossing out the if reporting, the word reporting, and we're crossing out the word performed. All right. So the way it used to look was do not report these codes reporting 99441 to 99444 performed in the previous 7 days. Now the wording is different. So it's just a little minor change, but it makes a significant difference. Okay, no questions. All right. The next revision, revise the exclusionary parenthetical note following code 99483. Remove the monthly chronic care management codes 99487, 99489, and 99490. Remove the transitional care management codes 99495, 99496, and add the health risk administration codes 96160, 96161. So there's a lot of writing here, okay, on page 47, column 2. And you'll move down to this section here where it begins in your book. Typically, 50 minutes is spent face-to-face with the patient and or family or caregiver. And we're crossing out the 994, 87, 89, 90, 95, and 96. And we're adding health risk assessment administration, 96160, 96161. So when you go on to page 47 and look column 2 and you look down and you see the phrase where it begins, typically 50 minutes, you'll see this in the little green, you know, triangles here, and you have to add those words and cross out the other codes that were that have been previously put in there. Now this one, the next one here, revise the placement of the navigational resequence alerts for codes 99485, 99486, subsequent to code 99480, to instead follow the navigational resequence alert code 99484 in the cognitive assessment and care plan services subsection. And I'm not even going to lie. This is, I was looking at this in the book and I'm saying, really? The 99480 is there and on page 47, and it's presented just the way it is. 99485, that whole thing is crossed off, and it's the code is out of numerical sequence, C99466 to 99469. And when you look at the book, it will make more sense. And the same thing here, the 99486 is crossed off on that same page, and it's saying code is out of numerical sequence C99466 to 99469. So when you're looking at that page, you just have to, cross it off. And here, it's when it says revise the placement of the navigational resequence alerts for codes 9948586 subsequent to code 99480 to instead follow the navigational resequence alert code 99484 in the cognitive assessment and care plan services subsection. My goodness, it was so hard just to find the codes because they're so out of sequence. But anyway, so in this particular case, we're going to be looking at pages 47, column 1, and page 54, column 2. So the 99483 is the new, is a new code, and it's as it is. And on 99484, which follows it, the code is out of numerical sequence, C996, 99466, 99499. And then when you actually go to page 43, column 2, you will find these codes, the 99485, 99486. That's where they're supposed to be placed. And again, they're indicating that the code is out of numerical sequence and that you're supposed to see 99466 to 99469. When I tried to put this on a slide based on what the AMA presented, even when I read it from the AMA slide pages and when I put it on my slides, it didn't make sense. It wasn't clear. But when I actually sat and went through my CPT manual with all of this information, it made perfect sense. So don't get too confused if you're looking at or hearing me and saying, I don't know what she's talking about. Just make sure if you're using the professional, you'll be lucky because I'm giving you the pages and the column, and you'll find it, and it'll be very easy to write the notes, okay? But this particular section was very, very challenging. Now, here we talk about revising the care management service guidelines to clarify services that are a requirement of care management services, clarify that creating a care plan is a requirement of care plan services, remove instruction related to clinical staff time on the same day as a physician or other qualified healthcare professional, clarify codes 99484, 99492, 99493, 99494. They may also be reported when behavioral or psychiatric collaborative care management services are provided. Delete the redundant also and add in addition to the last paragraph of the care management services guidelines. So when you turn to page 47 and you look at column 2, you have all these guidelines and you look at it. And the only thing that you're going to do when you read the portion and you'll match it right up to your CPT, the care management services are, and so forth, the services include in establishing, implementing, revising. You're crossing out the word may. Now, if any of you club members subscribe to Find a Code, whether on your own or through CCO, let me tell you that you don't even have to go through all of this. But if you don't use those, don't use their Find a Code, guidelines with CPT or whatever, you would have to definitely resort to your book. I use Find a Code and Supercoda all the time, but I still use my book just as much. So I edited my book, but all of these are already done. So if you actually went into Find a Code right now and looked at this guideline, the word may would not even be there. Okay, so if you don't want to be bothered with your CPT, that's the easy way to do it. And it just goes on, a plan of care. So, must be documented and shared with the patient and or caregiver. So you know where you are. I don't have to write the whole thing because it would be 4 pages long. Then when we get to page 48, column 1, and we talk about the revised care management service guidelines and complex chronic care management services, it will begin, you know, with the codes 99487, 8990, reported only once per calendar month and may only be reported by the single physician and other qualified healthcare professional who assumes the care management role with a particular patient for the calendar month. Here we'll see all of this in the CPT manual. And what they're doing is when they're telling you the face-to-face and non-face-to-face time spent by the clinical staff and communicating with the patient and our family caregivers, other professionals and agencies, creating, revising, documenting, and so forth. So they just added the word creating here. But then when you get to the bottom of the paragraph, there's a note, and you have to cross this entire note out. It no longer exists. So that's basically what you would be doing with these paragraphs on page 48. And this here, pages 48 and 49, column 2 for page 48 and column 1 for page 49. And we're talking about the revised care management service guidelines and complex chronic care management services. We have lengthy paragraphs that begin with the care management activities performed by clinical staff typically include, and you'll have your paragraphs, and then you'll find another paragraph, the care management office practice must have the following capabilities, skip over that, and then you get to this section. And what you'll be doing here is simply crossing off care management services and adding a physician or other qualified healthcare professional who reports codes 99487, 89, 99490 may not report. And it goes on, care plan oversight services. So before it used to say the care management services, and now it doesn't. It's a physician or other qualified healthcare provider. So that will be a change there. And as you continue down and you're reading about the care management and how it's reported on page 49, column 1, when you look here, you're adding the words when, behavioral, or are also provided. The CPT code 98484 is added. The word may and then be reported in addition is all added. We're crossing out the word for, and we're crossing out C and also. And so it's amazing how a couple of words can totally alter a definition, but that's basically all you have to do there. Now, when we look at the coding tip on page 50, column 2, revise the complex chronic care management services coding to remove instruction related to reporting codes 99487, 8990 based on the site of service. The very beginning of the coding tip, you will be crossing out the time of care management with the emergency department is reportable using and so forth. You will cross that completely off your book, but there is no change in the other part of the coding tip where it says if the physician personally performs the clinical staff activities and so forth. So you would not do anything with that. But the very first paragraph on this coding tip on page 50, column 2, cross it out. Here is, we're revising the psychiatric collaborative care management services table to accurately reflect the reporting for additional 30 minutes of reporting to exceed half of the required service. And it's really here on this code here, this line, where it's 86 to 115 minutes. This remains the same, which is basically 1 hour and 26 minutes to 1 hour and 55 minutes. And basically this table is on page 51. And all you're really doing is changing the 116, getting rid of that, okay, crossing that out, and you're making it 115 right here. So you're crossing out the 116 minutes and changing it to 115 minutes. And then where it's 1 hour and 26 minutes, you're going to cross off the 54 minutes and change it to 55 minutes. So it looks like this line here. Okay, and your table will be on page 51. The other coding tip that has to do with the psychiatric collaborative care management services subsection to remove instruction related to the reporting of these codes 994, 92, 93, and 94 based on the site of service. The first paragraph of the coding tip will remain the same, but you will cross off on page 52, column 1, the second part of this coding tip that begins with behavioral health care manager, time spent coordinating care with the emergency department. All of that will be eliminated. So that will definitely, affect you and how you code, for those type services. And this is page 55, column 1, and including the revision of the subsection for general behavioral health integration care management with the 994, 84, 92, 93, and 94 based on the site of service. And you will find that the first paragraph of the coding tip remains the same. The middle portion that begins with behavioral health care management, time spent coordinating care with the emergency department, all of this is crossed off and deleted. And then the second part of the coding tip remains the same. And that will be page 55, column 1. Now here, where it says revise the Lund-Broder diagram to reflect that the birth 1-year-old patient for the right thigh should measure 5.5. Trying to think. This, if you look at this chart, okay, on page 95, you will see one column and it says area birth, and it's going to say right thigh, and then the 1 year is the age, okay? So the right thigh, and you're going to change that 2.5 years to 5.5 years. And basically, the birth year is column 2, and you're going to change it from 2.5 to 5.5. If you look at the chart in your CPT manual on page 95, you'll see that when you look at the left thigh, it says 5.5 years. It was a typo. Okay, it was a typographical error, and so we're crossing off the 2 and changing it to a 5, and it'll match the left thigh, and the right thigh will then match. And you'll see the columns going down that have to do with the burns and the local treatment, and it all makes sense. It's just this one little typo error you have to fix. Now, when we turn to page 355, column 1, you'll see remove the parenthetical note following code 52351 and adding parenthetical notes following 52343 and 52346. So we go on to page 355, column 1, and we see 52341, 42, and 43. And you will see here that they added for radiological supervision and interpretation use 74485. These parenthetical notes have not changed. And the 52344, 52345, and 52346, all of this information will remain the same, page 355, column 1, and here also for radiological supervision and interpretation, they're telling you to use 74485, so you have to add that. When you go again to the 52351, which is on page 355, column 1, all right, what you're going to do in the there's a parenthetical note in there that says for radiological supervision and interpretation, use 74485. You have to cross that out. You don't use it with the 52351. This remains the same. You'll see this in the CPT manual. Then you want to add the navigational resequence alert for code 58674 to the oviduct ovary subsection as it was inadvertently omitted from the 2018 code book. So that's on page 377 in the second column. So the 58674, you will see code is out of numerical sequence, C58520 through 58542. And that you have to add to your CPT manual. Now, when you turn to page 44, okay, revise the code For HTRA1 in the molecular pathology gene table from 81400 to 81405, these are all alphabetically listed. And when you get to the H's, you'll see this graph, and you cross off the 81400 and add 81405. Now here on pathology lab drug assay definitive drug classes listing, revise the drugs and the amphetamines drug class of the definitive drug classes listing from ephedrine, dexamethasone and ephedrine and lisdexamethasone, whatever, and revise the drugs in the benzodiazepine drug class. So let's just look here. The 80324 to 80326 on page 519, you'll see amphetamines, and then here you'll be crossing off that word that I cannot pronounce, the ephedrine. My goodness gracious. You will add the ephedrine and you will add the lisdexamethasone, and these remain the same, those here. So you're crossing off this really long word that I cannot pronounce, and then these two other words will be added. And then in the next column beneath that, the 80346 and 47, the benzodiazepines, you're crossing off this long word here, halazepam, lorazepam, diazeloam, or whatever, and you will add halazepam, lorazepam, and midazolam. Okay, so that's all you're doing there on that chart. Now, when we get to page 595, column 1, the proprietary laboratory analysis, we're revising the proprietary laboratory analyses guidelines to reference the proprietary listing of PLA codes and Appendix O. Define the appropriate code selection for duplicate descriptors with differentiation only by the proprietary name, and addition of a new symbol, which looks kind of like an H, to denote duplicate PLA codes. Editorially revise the introductory proprietary laboratory analyses guidelines from it is denoted to code, the codes will be. So on the very first column, when you're reading all the information about the PLA codes, the next paragraph you will see, you know, in column 1, you'll be crossing off these codes and changing it to this subsection includes, all right, advanced diagnostic laboratory tests and clinical diagnostic laboratory tests as defined under the Protecting Access to Medicare Act of 2014. And then all of this is added as the descriptor. These analyses may include a range of medical laboratory tests, including but not limited to multi-analyte assays with algorithmic analyses and genomic sequencing procedures. The descriptor nomenclature follows where possible existing code conventions, example MAAA, GSP. Now, I'm not someone that has ever coded or even billed for laboratory, and I'm the first one to admit it. So I understand what the changes are, but if I was asked to explain it, I would have to tell you I really couldn't. I would have to do a lot of research on that. Page 595, column 1, you will be adding all of this, like I said, all these new symbols. These codes are not required to fill the category 1 criteria. The standards for inclusion in this section are the test must be commercially available in the United States for use on human specimens, and the clinical lab or manufacturer that offers the test must request the code. For similar lab analyses that fulfill category 1 criteria, see codes listed in the numeric 80,000 series. So you would have to add all of this where the guidelines are. And there, and then continue. All of this information is added when the PLA code is available to report a given proprietary lab service and so forth. So there's a lot that needs to be added. If it's not something that you typically code for, you might just want to print out either this or, like I said, the AMA, I think it's 27 pages from the AMA, and just stick them in the pages of the CPT. Again, we're still talking about the revision of the proprietary laboratory analysis guidelines. Codes, and this is all new descriptive. Codes in this subsection are released on a quarterly basis to expedite dissemination for reporting. PLA codes will be published electronically on the AMA CPT website, and here it is. I put it in bright blue so that you could copy it down if you had to. Distributed via CPT data files on a quarterly basis, and at a minimum made available in print annually in the CPT codebook. Go to, and here's the other website for the AMA media browser, so forth, for the most current listing. And all of that is new. And then this is all added in addition, meaning all codes that are included in this section are also included in Appendix O. And at the very bottom, it'll say when more than one PLA has an identical descriptor, the codes will be denoted by the symbol H or whatever it is. And cross out, it is denoted. And still talking about the revision here, editorially revised the introductory proprietary laboratory analyses guidelines from it is denoted to the codes will be, which we just saw. When we go to page 595, column 2, you will see this new symbol in front of this new code. All of these are new codes. 000707U, which is the drug tests that were all new for 2018, if you remember. And beneath each of these codes, for additional PLA code with identical descriptor, C0020U. See Appendix O to determine appropriate code assignment. Then we have our new symbol here, and this is also a new code for 2018, the 0020U, and it describes the drug test. And it also tells you for additional PLA code with identical clinical descriptor, see 00070, see Appendix O to determine appropriate code assignment. So you have to change those. Now, when we go to the category 3 codes, we'll go to page 749, column 2. And the 0487T was a new code for 2018, biomechanical mapping, transvaginal with report. And then we have the 0488T. Code is out of numerical sequence, and we have to cross out C0486T through 0489T and add 0402T-0405T, okay? Because that's actually where it's out of numerical sequence, not here. Now here, add the sunset dates for category 3 codes 0488T through 0504T, as they were inadvertently omitted from the 2018 codebook. So you will find these category 3 codes starting page 749, column 2. And all you will see added with all these codes that are in place in your CPT manual is sunset January 2023. And that is after each description of these category 3 codes. This is column 2, still page 749. Everything's exactly the same, except that underneath it's added sunset January 2023. And it continues into page 750, column 1. From 749, column 2 to page 750, column 1. And the only thing that's different is the sunset, January 2023. Okay, so, and this is all page 750, column 1 in your CPT manual. And it keeps on going. Column 1 and 2. And there should be 2 more codes, right? And they're all in your book. And again, you can just do like a big bracket or something and just do sunset January 2023, you know, or just make a little note at the top of the pages, because it's really, that's the only change for that. Now, when you're looking at Appendix O and we're talking about the multi-analyte assays with algorithmic analyses, it's page 810, column 1. And the only thing that you'll see is that the following list includes 3 types of CPT codes. And this is all new, multi-analyte assays with algorithmic analyses, MAAA, administrative codes. Category 1, MAAA codes, and 3 proprietary laboratory analyses, PLA codes. And this was all in your CPT manual. You just had to put this at the very beginning of Appendix O. And this is all exactly as it's listed in your CPT, the Appendix O. The list includes a proprietary name and clinical lab or manufacturer in the first column, and alphanumeric code in the second column, and a code descriptor in the third column. The format for the code descriptor usually includes in order. And this is listed on page 810, column 1 and 2, and it's listed exactly like this. And same here. And it's page 810. But then at the bottom of 810, column 2, you will see that they added additions in the section may be released triannually, and then in parentheses, or quarterly for PLA codes. And then the second set of guidelines in the triangles, the words when applicable is added. So that's, you go through Appendix O and you're going through everything that I just showed you, and it's verbatim. You don't have to change anything. When you get to the bottom, you just have to make these couple of additions. And if you need more information, here's the link for that. Okay. And again, the codes in this list are provided as an administrative coding set to facilitate accurate reporting of MAAA services. The minimum standard for inclusion in this list is that an analysis is generally available for patient care. The AMA has not reviewed procedures in the administrative coding set for clinical utility. The list is not a complete list of all MAA procedures. And this is all new that's added to the Appendix O here. Now, what I'm going to show you here, this is pages 811 through 814. And this was all provided in the listing from the AMA for the Appendix O. And all of the proprietary names and clinical labs and manufacturers, everything is in your CPT. You just have to compare those notes, okay? And there's some information like the 000M has been deleted, use 81520, and so forth. And this is just a continuous page, and you can just, look and compare all of these, in your manual, and it just keeps going. And we're still in the Appendix O, and what they added was basically proprietary laboratory analyses under the multi-analyte assays with algorithmic analysis. And this is all new, all of this right here. All of it. So that's just to show you. And here is like the new symbol that we've looked at, and all of this here, you'll see certain things that are underlined. That is in addition that you would add. But you'll see this, and you'll see that most of it will match, but then some of it where it's underlined, you'll see that it's different. But this is what it'll look like, those pages. Okay. They're almost at the end, and I know that it's just really going over the pages, and it can be a little bit boring. And if it doesn't relate to what you're actually doing in your job, then, keep it in your book, but you don't have to write up your whole CPT. Here we have revise the consumer descriptor data file for codes 52441 and 52442 to indicate an implant into the bladder canal within the prostate gland. And you look at this, and it's the insertion of implant, and you're crossing out the word material. and you're adding canal, urethra within prostate gland in that description. And in the 52442, insertion of implant, crossing out the material word in bladder, canal, urethra within prostate gland using an endoscope. And you want to note the descriptors in your CPT manual are completely different. The 55242 is no longer an add-on code. All right, and that's very important. So that's page 355, column 2. We only have a couple of more slides. This one, if I would recommend that you print out or download this file. I'm going to see if I can open it for you. I don't know if I can open it. See if I can. And here you'll have, this is the one you want right here. All right. And it's 27 pages long. Because I took excerpts from this to give you an idea and what pages to look at, but this will probably be more consolidated. You could actually cut it up and staple it to the page or do whatever, but that is the link that you would use right here to get the exact printout that the AMA is offering. Okay. And lastly, if you want to sign up to receive email notifications, as I do, and that's how I found out about all of these changes and whatnot, here is the link for this as well. And this is for changes posted to the AMA website for CPT announcements, Category 2 codes, Category 3 codes, vaccine codes, errata and panel agenda proposals, and subsequent actions. And you may also receive notice when registration opens for the CPT editorial panel meeting. So those 2 links would really be helpful, because that way you would be one step ahead of everyone, because you would get these notifications as I did. And as I said, the handouts here are great, but you're more than welcome to get the 27-page from the AMA. It may be easier to handle, and in coloring that might be more understandable for you. And that is it for tonight. Oh, oh, and Whitney, I'll keep my fingers crossed. So you took the exam last Saturday. So next club, I want to hear if you passed. I'm sure you will. You are such an excellent student, and you follow everything on CCO to keep educated. So I think you'll do just great, and good luck. And Boyd says we have no more questions. So I wish you all a good night, and I will be seeing you all soon. Have a good night.